Hello guys, welcome you at your YouTube channel for the medical student. So guys, in last class we have discussed about the diabetes mellitus in children, and in continuation of this there is the diabetic ketoacidosis in children, as DKA is the complication of the diabetes mellitus. It is very important, and today we will discuss here about the introduction, definition, pathophysiologically clinical features, diagnosis, complication and management of the diabetic ketoacidosis. And guys, diabetic ketoacidosis is important, acute, major and life-threatening complication of the diabetes mellitus, and it occurs in patients with the type 1 diabetes mellitus more frequently, and in special condition it may also found in the type 2 diabetes mellitus. And guys, it usually precipitated by the infection, any stress or trauma, and it is result from the decreased insulin or shortage of the insulin causes the hyperglycemia or lipolysis, which causes the production of the free fatty acid and ketone bodies that causes most of the symptoms and complication of the diabetes mellitus or DKA. So guys, it is defined as a state of absolute or relative insulin deficiency resulted as a triad of all hyperglycemia, ketosis or acidemia. So guys, DKA, diabetic, means the hyperglycemia as blood glucose level is more than 250 mg per deciliter, and ketosis as elevated urine or serum ketone level is more than 5 milliequivalent per liter, and acidosis or acidemia as pH is less than 7.3 or bicarbonate level is less than 15 millimole per liter. So guys, its severity of DKA is defined or classified as mild, moderate and severely on the basis of bicarbonate, pH and condition of the children. As the mild is if there is bicarbonate level is less than 20 or pH level is less than 7.3, along with the patient is oriented, alert, but the patient feeling some fatigue. And in moderate cases, there is the bicarbonate level is less than 10, pH is less than 7.2, while the patient having the kussmaul breathing or respiration is altered, or patient is conscious but feeling sleepy, but patient is arousable. And in case of the severe DKA, there is severely bicarbonate level is decreased as less than 5 milliequivalent per liter, along with the pH is less than 7.1, with the kussmaul breathing or depressed respiration, along with the sleepy or depressed condition, with the sensorium is lost or patient may found in the coma. And guys, if there is hypernatremia or corrected sodium level is more than 150 milliequivalent per liter, it should be considered as the severe diabetic ketoacidosis, because there is the hypernatremic dehydration in case of the DKA. So guys, in the last class, as we discussed in the diabetes mellitus as the physiological background of the insulin and its counter-regulatory hormone of the glucagon, as the insulin work as the use of the glucose for the energy substrate and storage as the glycogen, and its formation or acceleration of the production of the protein, and fat can be stored in form of the triglyceride, and it's the counter-regulatory hormone at the glucagon causes the glycogenolysis, proteolysis, and gluconeogenesis causes hyperglycemia, which causes osmotic diuresis, causes dehydration, and lipolysis may causes free fatty acid and production of the ketone bodies. So guys, to develop the DKA, there must be both relative lack of the insulin along with the relative overactivity of the counter-regulatory hormone of the glucagon. So guys, pathophysiologically there is severe insulinopenia or level of the insulin is decreased, resultant in the 3 general pathways as the excessive glucose production or decreased glucose utilization, causing the hyperglycemia, which causes osmotic diuresis, which causes severe dehydration, and loss of the electrolytes and activation of the renin angiotensin aldosterone axis, which causes accelerated potassium loss and risk of the cerebral edema due to the osmotic diuresis. And guys, there may be increased catabolic process as the cellular loss of the sodium, potassium and other electrolyte as the phosphates. And guys, there will be the increased release of the free fatty acid due to the lipolysis process causes accumulation of the ketoacidosis or ketone bodies, and buffer system are depleted causes metabolic acidosis, ultimately causes acidosis. So guys, there is three major pathways or pathological system is found in the DKA physiology as metabolic acidosis along with the electrolyte disturbances with the osmotic diuresis. So guys, diagnostically DKA should be suspected or it may be presented at the initial symptoms of the diabetes mellitus type 1 in case of 20 to 40% cases. And a patient of the diabetes mellitus, if having inadequate insulin treatment or non-compliant, having any acute illness or infection or taking any drugs as the olanzapine or lithium, we should suspect the case as DKA. So guys, there is the clinical features of the DKA as the symptomatically DKA may be the first symptoms of the diabetes mellitus, and there may be associated with the nausea or vomiting due to the beta hydroxybutyrate. There may be polydipsia or polyuria along with the nocturia, or there may be some polyphagia. Abdominal pain, shortness of the breath due to the metabolic acidosis, and weakness due to the decreased perfusion, and fruity breath odor due to the ketone bodies. And guys, signs are presented as the dehydration, hypotension, tachycardia, tachypnea due to the kussmaul breathing, or there may be acetone odor in the breath, abdominal tenderness may be found, or patient as presented with the lethargy or altered level of the consciousness may be presented with the coma. So guys, as the lab investigation is presented as the serum glucose level is very high or more than 250 mg per deciliter, electrolyte level may be deranged as the hyperkalemia or hypernatremia, bicarbonate level is decreased due to the acidosis, and amylase and lipase level may be deranged. Urine dipstick shows the ketonuria or glycosuria, and serum capillary beta hydroxybutyrate level may be increased. ABG shows the metabolic acidosis. CBC count is increased due to the infection, or urea electrolyte imbalance may be found, and urine and blood culture may show organism in case of the infection, and ECG showing some changes due to the hyperkalemia or other electrolyte imbalances. So guys, imaging can be required in case of the infection. Chest radiography is required in case of the pulmonary infection, and head CT or MRI is detect the early cerebral edema. So guys, management of DKA is very important, because initially if we are treating the DKA or initially be taking the aggressive measure, we can save the life of the child, and we should restore the perfusion, correct the ketoacidosis or ketogenesis process should be arrest and restore the normal acid-base balance, replace the electrolyte losses, and if there is any complication should be treat or intervene. So guys, there is Milwaukee protocol to treat the DKA, as there is initial first hour is very important, and we should hydrate the patient with the bolus of normal saline as 10 to 20 ml per kg bolus with the normal saline, or ringer lactate can be used here for the quick volume expansion, and it may be repeated up to the 60 ml per kg, and nothing per oral to be given, and monitor input output is very important with the neurological status of the child. Insulin drip can be started at the rate of 0.05 to 0.1 international unit per kg per hour initially. And guys, after the 1 hour, when the hydration process is started, we should change the normal saline to half normal saline, and insulin drip to be continued. So guys, IV drip rate to be given at the following formula, as there is should be calculated as the dehydration fluid along with the maintenance fluid minus the bolus. As if there is 30 kg child, 85 into 30 is the dehydration fluid plus the 1700 ml is the maintenance fluid of the 24 hour minus 600 ml bolus as given initially at the rate of 20 ml per kg. The total fluid is 3650 ml to be given in the 23 hour at the rate of 150 ml per hour. This is the fluid to be given. Guys, there should not be overcorrection or rapid correction of the fluid to prevent the cerebral edema. And guys, when the patient passes urine, we should give the potassium at the rate of 20 milliequivalent per liter of the replacement fluid, and 5% glucose can be added if the blood sugar is less than 250 milligram per deciliter. We will discuss in later on. And guys, when the patient having no emesis, bicarbonate is corrected, acidosis is corrected, bicarbonate level is more than 50 milliequivalent per liter or normal electrolyte is found, we should shift to the oral intake and subcutaneous insulin. So guys, one by one we will discuss here. As the IV fluid to be started as the normal saline initially 0.9% 1 to 2 hourly till the plasma volume is replaced, and it shifted to the 0.45% normal saline till the blood glucose is 300 milligram per deciliter. When the blood glucose is less than 300 milligram per deciliter, we can add the 5% dextrose, and if the blood glucose level is less than 200 or less than 180, 10% dextrose can be given. Guys, if the blood glucose level is falling continuously or less than 100 milligram per deciliter, we can decrease the insulin, because the insulin can work for the acidosis, or ketone may be decreased at the rate of 0.02 to 0.05 international unit per hour. So guys, this is very important, and we should not correct rapidly dehydration or hyperglycemia, because it may cause cerebral edema. So guys, insulin to be started at the rate of 0.1 international unit per kg per hour, and it should not be given a bolus, or it is very important that 0.02 to 0.02 to 0.05 unit per kg per hour are usually sufficient to decrease the acidosis. So guys, to stop the insulin, there is criteria as the acidosis to be corrected, and clinically or pH, and there should be negative ketonuria, or child is eating well and having good looks with the feeling good. So guys, this is the criteria to stop the insulin. And guys, important is potassium replacement. Initially, the total body potassium is deficit but may presented at normal or high potassium level due to the decreased insulin level or acidosis, where the extracellular shifting of the potassium from the cells. And guys, we should start the potassium after taking the potassium serum potassium level, and when we start the correction of the acidosis with the insulin, the potassium level is shifted extracellular to the intracellularly, so the potassium level is decreased, and we should start here the potassium replacement at the, if the potassium is less than 5 milliequivalent per liter at the rate of 20 milliequivalent per liter of the replacement fluid, and if the potassium is less than 4 milliequivalent per liter, 40 milliequivalent can be given in the replacement fluid, or if we are treating the acidosis with the soda bicarbonate, potassium replacement at the rate of 40 milliequivalent per liter of the replacement fluid. It may be increased up to the 80 milliequivalent per liter if the serum potassium level is less than 3. So guys, it is very important to correct the hypokalemia. And guys, sodium is very important. Hyponatremia or initial sodium level is usually normal or low because of the osmolar dilution of the hyperglycemia. And guys, where the true sodium level is very important, at the adding of sodium at the rate of 1.6 milliequivalent per liter of the sodium in every 100 milligram per deciliter of glucose in excess of the 100. So guys, if the corrected value of the sodium is more than 150 millimole per liter, there should be suspected as the severe hypernatremic dehydration, and it should be treated as the severe diabetic ketoacidosis and presented may require as the cellular fluid replacement. Guys, declined sodium may indicate the excessive free water accumulation and which increase the cerebral edema risk. So guys, acidosis is very important feature of the diabetic ketoacidosis, but it should be corrected with the rehydration and insulin infusion. Usually bicarbonate is not required, but it may be considered if the pH is not improved after the correction process of the rehydration and insulin, and arterial pH is remain less than 7 or venous pH is less than 6.9 or sodium serum bicarbonate level is less than 5 to 10 milliequivalent per liter. But guys, it should be discontinued once the pH is more than 7.1 or bicarbonate level is increased to more than 10 milliequivalent per liter. So guys, there is very important to monitor the electrolytes and pH in case of bicarbonate infusion. So guys, in case of DKA, we should monitor the input-output hourly basis to adjust the fluid in every 4 hourly, and venous pH, soda bicarb and ketone to be monitored in every 2 hours. It may be required less frequently in later stage, but the acidosis is severe or bicarbonate is giving, we should monitor these level at hourly basis, and blood glucose to be monitored on the hourly basis, and electrolytes can be monitored in every 2 hours, or if the patient is stable, it can be monitored in every 4 hours. So guys, complication of DKA as dehydration, hypotension or shock, metabolic acidosis may be there, hyperkalemia, hypernatremia, hypoglycemia is very important due to the treatment of the insulin, aspiration pneumonia or due to the infection, there may be sepsis, acute tubular necrosis may be there, or stroke. Or guys, there is very important lethal complication or mortality due to the DKA's cerebral edema, where the around 1% cases of the childhood DKA having high mortality with the neurological morbidity, and it is attributed to the cellular swelling as a result of rapid osmolar changes occurring during the IV infusion or treatment with the insulin, and it is presented as the gradual deterioration and worsening of the consciousness level or gradual general improvement followed by the sudden neurological deterioration. So guys, the clinical feature of the cerebral edema is presented at the decreased sensorium along with the sudden or severe headache with the incontinence, persistent vomiting is there, deterioration or disorientation and agitation may be there, ophthalmoplegia or papillary changes is there, papillar edema, if the papillar edema may be there along with the changes in the posture or seizure may be presenting feature of the cerebral edema. So guys, cerebral edema should be managed urgently or promptly with the 3% normal saline or mannitol 20% IV can be given at the dose of 0.5 to 1 gram per kilogram infused over the 30 minutes, along with the raising the head end at the 45 degree with the reducing of IV fluid at the rate of 70% of the maintenance fluid, and if required, intubation and hyperventilation may be required. When the patient is stable, oral glycerol can be shifted. So guys, this is cerebral edema, and summarize as the DKA as common and serious complication of the patient with the diabetes, and we can prevent the metabolic decompensation through the patient education or parent education, strict surveillance of the glucose homeostasis, and aggressive diabetes management might reduce the high mortality and morbidity associated with the diabetic ketoacidosis. So guys, this is all about the diabetic ketoacidosis. And guys, if you did not subscribe our channel yet, subscribe the channel, press the bell icon and share it to the all medical students. So thank you very much. We will meet again with the next topic.